Thank you. Hello. I want to extend a warm welcome to EMS Caucus members, staff, distinguished guests, and partners. I am Susan Bailey, president of NAEMT, and I will be your MC for today's meeting. I want to thank co-chairs Richard Hudson and Debbie Dingle for allowing NAEMT the opportunity to help educate lawmakers on the unique and often unmet needs of the EMS community. I will now turn over time to them for a few brief remarks of welcome.
Hi, this is Congressman Richard Hudson. It's great to speak to all of you today, and I appreciate the National Association of EMTs for putting this great event together. In Congress, I'm honored to serve as co-chair of the EMS Caucus, along with my friend, Representative Debbie Dingle. Our first responders, emergency medical technicians, paramedics, and all others in emergency medical services play a critical role in every community. I want to personally thank all EMS workers for what you do every day. Unfortunately, I believe your work is too often not recognized as much as it should be at the federal level, which is exactly why Congresswoman Dingle and I formed the EMS Caucus. EMS is a critical part of the healthcare industry, and your role has evolved beyond a patient delivery service. With EMS personnel providing critical healthcare services, it's time to start thinking more creatively about how to ensure a strong and resilient EMS system. This is about more than money, but it's also about reform and regulatory changes and flexibility. We should be doing much more to raise awareness of the services EMS provides, how EMS fits into our overall healthcare system, and how EMS is staffed, funded, and delivered. We know just how important your work is across our country, including in my state of North Carolina. In fact, I've recently supported Sanford, North Carolina's request for the SAFER grant funds to hire more firefighters and expand their trucks, housing, and equipment. I look forward to seeing these visions come to life in my district and communities around the country. I've also helped push for and secure funding for the National Association of EMTs through the Siren program. As you all know, these funds are crucial to rural communities like my district. In this EMS week, we are proud to recognize you and your fellow EMS practitioners for all you do to keep our community safe. So once again, it's an honor to lead the EMS Caucus in the 118th Congress, and I invite my colleagues to join Representative Dingle and me as members of the caucus. Together, we can continue to support and promote the important work of all EMS practitioners. Thank you, and enjoy today's program. God bless you.
Hi, everyone. It's Congresswoman Debbie Dingle here from Michigan's 6th District. More importantly, I am proud to be a co-chair of the Congressional EMS Caucus. I know the role that they play on the front line every day, and I'm thankful to all of you for joining this briefing today to learn more about the critical functions that EMS plays every day in keeping our community safe and what Congress is doing to support EMS workers. And thank you to my co-chair, Rep. Hudson from North Carolina, for his partnership. Emergency medical service professionals are on the front lines of our health and public safety every single day, and they provide life-saving services in some of the most difficult and unimaginable circumstances. I've seen it. I've witnessed it. I've been there with them. EMS providers are literally lifelines for communities and play an especially critical role throughout the coronavirus pandemic. They didn't have the option of wearing masks and staying at home. For me, the firefighters in my community are my brothers and sisters. I began working with the Dearborn firefighters decades ago. And when my husband got sick, they were angels. Why, I did know what they did every day. When you're suddenly in the real world, you really begin to understand what they do. The Dearborn firefighters were always there, trying to help me and him and handle whatever happened. And every last one of them was kind, compassionate, empathetic, good, supportive, loving people who helped me through one of the most horrific times of my life. and they never left me. And they were there the night John died. They loved John, and John loved them, and they were part of my family. Last week, I joined my colleague Representative Joyce in introducing the Siren Reauthorization Act to support EMS agencies in rural communities. The Siren program helps recruit and train a strong EMS workforce that can address the toughest of challenges and be there for our communities in their times of need. I'm spending a lot of time understanding what happens in rural communities when there is an emergency and how we get people there. I've also introduced legislation this week to make sure that the equipment that emergency responders are wearing is safe, doesn't have toxic chemicals like PFAS, and we're keeping them safe on everything. I think this conversation you're going to have today is so important, and I reaffirm with you that I will always be committed to supporting the needs of our EMS workers and agencies. And I want to hear from you about what we need to do to help support you. I'm out there, I go into my community, I meet with my ambulance workers, my EMS, and my fire in every community that understand it. Let us know what we need to know. So we're committed to making sure you've got what you need. Thanks for what you do every day. And I'm sorry I can't be there in person with you right now.
I'm going to say that just like everything else that we do in EMS, it is varied. It varies from state to state. It varies from county to county and city to city, and the agency type. So if you belong to a very large organization, being able to obtain training resources can be kind of an easy thing because you have the ability to fund it. You have the ability to access. You have resources and people to be able to fill that need. The smaller your agency, the different your funding model, you may or may not be able to access the training resources that you need. And so I know that I'm going to jump ahead real quick. I'm just talking about rural responders, but our rural agencies, they're hurting for these types of resources, and it's very difficult for them to get what they need in materials, but also in staff. And we're talking about levels of expertise to be able to teach, to be able to conduct the sessions. So the smaller the agency, the harder it is. And depending on the funding model, they may or may not be able to afford it, even if they have a staff professional to be able to teach the material. So agencies like mine that come from a larger area that are more funded and well supported, we try to spread the wealth of our educational opportunities to those rural providers, but we're strapped as well. We have to take care of our own needs, and it's really stretching things and resources very, very thinly.
Dave Edgar from West Des Moines. So I guess to answer the last question first, whether it's Siren or this, it's essential that we keep these things going. We just have to continue to work on how to get those types of things out to people. And I'm not sure I know there's a lot going around about the cancellation of the ET3 program. I can tell you that in order for those to work, especially when we're kind of in crisis mode, sometimes it's difficult to do things that are going to help you when you're running around on fire. And I find that in the hospitals, and I find it in EMS. But the requirements that were there, we briefly looked at it, but there were some things, and the hospitals, the healthcare systems don't want to participate. So take away the treatment at home, but if you can't get the healthcare systems to participate in helping you to navigate, I think if you talk to ER staff, they would love the ability to navigate and keep people at home. If you go about one step above them, they have zero interest in doing that. So it's unfortunate that they've decided not to do the program because it's essential for solving a lot of problems. But I'm afraid they, from what I understand, nobody really knew was happening or why maybe it wasn't successful during the pandemic.
So where we are, my county is very large, about 750 square miles. We got about 700,000 people, and we're just north of Tampa. And my county has everything from super rural to urban. Um, and that depends on what side of the county you're on. Is kind of what the type of calls and demographics that we're running on. But for us, we got even as big as we are, we got a super tight budget. And if anybody knows anything about Florida, we've seen unprecedented population growth that we quite frankly weren't prepared for. And we saw a 16% call volume increase. I believe it was in 2021 alone. And we've stayed up, with that. So we usually 4 to 5%, and then it just went to 16 all of a sudden. So we're running, 110,000 calls a year almost. We're doing it with 30 rescues. We've initiated a peak hour trucks. We're doing 2 12-hour trucks on that Panama schedule. And we actually we have a grant funded mobile integrated health program, but it focuses on opioid addiction, substance use disorder. We would love to see something like that. I think that's the biggest problem is the way that the reimbursement works. We just the other day I was having this conversation, and we had one of our hospitals on bypass. It's July, and we're not even busy yet, and we already have hospitals with 4 and 5 ambulances waiting 3 and 4 hours to drop patients off. And most of these patients probably could have gone to an urgent care or to some other type of clinic, and gotten the same care that they need. But the fact that we can't be reimbursed for that, we can only take them to one place. That really limits us, and then it bogs down the hospital system. So if there was something in place, that we could, bill for for treatment in place, or taking patients to urgent cares or something, or to help us build, a community paramedicine mobile integrated health team, where we might be able to, partner with our hospitals and do direct admissions for patients. We can go out and find some of our low acuity patients, say, yeah, we're going to get you to the hospital, just not right now. Build up a BLS program or something. Everything we do is, it's all fire department transport, ALS. We do have private providers in our county, but about 87% of the time, I think was the last statistics I saw, they're not able to help us. So our response times are getting worse, and because we don't have enough rescues to manage the volume. Then when we do, we don't have hospital beds to put patients in. So we definitely have to shift gears somewhere as an industry and find better ways to, to get our patients the care that they need.
We have to move past the 1970s thought. EMS is not about transport. We are not simply delivering a patient to the medicine. We are the medicine. We are not Uber. We are DoorDash. We are bringing the medicine to the patient. We need to be treated as such. We are not a ride to the hospital. We are the medicine before the hospital. I think that has to be somehow changed in the way that we view ourselves and in the way that we get reimbursed for our expertise. We need to be paid here for the services that we actually provide, not for the mode of transportation in how the patient got there. We all have to do a much, much better job selling the highlights of our various departments, career fields, whatever it may be. There really isn't any real great way, aside from volunteering, to I guess very much bring in a lot of these potential hires early on, right? So only in the last couple of years have we really started working on a high school cadet technical type program, bringing in these kids when they're 16, 17, 18 years old, having them focus more on the medical side. I think if we can bring them in when they're younger, it'll be much more likely to have them stick around, stay. We don't typically get a lot of people changing their actual career, at least not for us, in their 30s and 40s. We will very commonly have the people showing up fresh out of their time in the Army, the Air Force, Coast Guard, whatever. But aside from that, by the time most of them are 25 to 30, they've already decided to not work in this field. So if there's any type of resources we can have to help us to very much help us capture these younger people, it'll definitely make our lives probably a whole lot easier through either through some type of grant here for ENT training, paramedic training, especially for our more rural partners that maybe can't offer all that training as like part of their in-house program. If there's a way to help us have that funded a lot better, that would definitely be helpful for us.
I'd like to add on to that because again, our system is a EMS only system. So in order to retain people in the medical field, number one, we got to stop talking about it as a temporary thing and move on to other things, in my opinion. We also have to correct issues with, in order to advance, you have to do another job outside of medicine. In our area, we pull people that are, it's an advantage both for our fire department and EMS because we're the only area here and it's a recruiting advantage for us. So people that want to be firefighters, which are still integrated within our system, but then there's a career path all the way up to division chiefs to, assistant chief that EMS practitioners can go. But, sometimes we get used to saying that, well, it's a stepping stone for other things. And certainly it can be for some people, but it's not for others. Now, I'm going to put on my rural hat. They're doing whatever they can to get anybody. I've got one rural hospital that I recently met with has had an opening for 1.5 years for a paramedic and has had no applicants. So that's an entirely different ball game. And you know what the hospitals are doing in that area? They're sending patients that would have been ALS, and this kind of shocked me. Maybe it's happening other places. They're sending them now BLS. So let me give you an example of that. Your grandmother lives in a rural area. She falls and breaks her hip and goes to the local hospital. Now she's being transferred 2 hours away to another hospital with a basic crew that can't provide pain medication to her on that ride. That's the reality of what's happening in the rural areas right now.
I started in this business as an explorer as a teenager. I've always known this was the job that I wanted to do. And I've actually been partnering with one of our local high schools to do a fire academy and EMT school while they're in high school, and at least get them through firefighter 1 and EMT by the time they're done. Because I've kind of recognized that I grew up poor. I didn't have a lot of money growing up, and when I went to the fire academy, it was $750. EMT school was like $300 when I went to the school in the 90s. Now EMT is $3,000, paramedic is $8,500, fire academy $7,000. And for the most part, people just don't have that money. It's difficult to have that money, and I think the other side of that too is I don't know that we set the expectations of what this job is very well with new people coming in. They watch things like Chicago Fire and they see all these fires and all these crazy calls and all this stuff happening, and they don't know that they're going to spend 80% of their time helping Mrs. Smith up off the floor, and holding her hand to the hospital. They don't get that, and they come in and then they're very, very busy, running 20 calls in a 24-hour shift of just helping Mrs. Smith up off the floor, a lot of the times. And, they're young and they're eager. And once they finally get here, and then this is like, oh man, the other side of it is, like you pointed out, it's the time, it's a stressful job. It's a physically demanding job. There's missing meals and missing all kinds of stuff. And I don't know that I think we kind of put it out there, but I don't know that we do a great job at it. And, sometimes, these kids, you're like, hey, you don't have relief, man. You got to hang out till somebody gets here. Well, I'm not staying. And then they leave. And then, you just, in a lot of places you get fired for that, but now it's like, well, hell, if I fire you, now what? I don't have anybody to replace you with. So, we've seen a significant reduction. We've lost a lot of people, even where I work, and a lot of it's to pay. It's a significant amount of it's to pay. Nobody wants to do the service job, and they definitely don't want to do it, for less money than you can make it working at McDonald's. So, I think we definitely need to fix the pay, need to fix the benefits. A lot of single service EMS agencies, they don't have a pension, especially private companies. They're lucky to get a 401k. They have significant, employee contributions into that 401k. And what's the life expectancy of that? Is that 401k going to be there in 25 or 30 years when they finally retire? And is it, what does that do for them? So I know, specifically in our area, private EMS is, they have some of them, but it's largely a stepping stone to fire departments, unfortunately. And I know that's just where we're at. I know there's plenty of areas where, you can be a private EMS or just, even if it's a municipal EMS service, sometimes they're the only paid service around, firefighters are volunteers. So I think there's opportunities out there, but I think, I agree with Anthony. We got to start getting these people young, and we need to teach them early what this job is about. And I'll be quite frank, I think that the online education, going to paramedic school online, it's ineffective. It's not working. And it's not training our people right, and then they're coming out and they're having major problems as practitioners, clinicians. We're basically teaching them to pass a test, and once they get out here, you're talking about a generation who struggles talking to people because they spend their whole life buried in their phone, and now we put them at 22, 23 years old. We bring them to Mrs. Smith's house on the worst day of her life, and we want them to manage that, and they don't have the skills to do it yet. So I think we need to work on developing our people on the other side of that too.
Well, we have a problem in EMS, leading back to that original statement, that we're very fractured across the nation. We're fractured not just on the design, but also on the expectations of what does EMS education look like, what the degree level is required, or should a degree be required? Is this a vocation or is this a profession? And it's very difficult to answer the question of what educational barriers do we truly have when we can't even agree on what is the education. And so that becomes a very difficult task to try to do. So some states, such as Kansas and Oregon, which I've been fortunate to live now in both, require an associate's degree to become a paramedic. They're looking at becoming a professional in this organization, similar to other healthcare industries, so like nursing, respiratory techs, where it is a degree field that gets you a different, rounded type of perspective and ability to be a critical thinker and problem solver. Other areas don't require that; they require a certificate to be able to become a professional in this field. And that certificate doesn't necessarily have that same emphasis. It's more on that whole passing the test, like what Jeremy and Anthony were talking about. Pass the test and then you can do the work, right? And so it's a matter of, us as an industry or as a profession, what is it that we truly need and what is it that we truly want? I don't disagree with, trying to get people in earlier and younger, because that is true. A lot of people that have that vision of what they want in their life when they're young tend to kind of stick with it. But what everyone's kind of alluded to in our discussion so far is this thing that I call the worth it factor. Is being an EMS worth it? And we've hit upon some of the difficulties of whether or not staying in this line of work is worth it, because FedEx and UPS are hiring right now for $25 and no training required. And there's not the same level of risk that we all encounter. We go to the same dangerous call scenes that police and fire go to, but we have less benefits. I know in my area, if you're not a sworn firefighter or a police officer, even though you go to the same calls, you do not get the same retirement plan for the state. You have a different plan. So even the benefits are different being an EMS provider. It's not equitable. So that worth it factor kind of goes down a notch. And then we talk about just the different risks that we face on scenes from family members, patients attacking. In fact, just recently in the news, I believe you all recognize the stabbing that just happened. I believe it was in New York. We have people that are being assaulted regularly. You have diseases that are transmitted. You have all sorts of obstacles for someone to actually stay in the field once they enter the field. And I think we have a lot of work ahead of us to try to figure this stuff out. It's more than just the pay.
Yeah, I think you'll find most agencies, again, that have the ability and the staffing to do it, that'll offer peer support programs. And I think that's pretty much becoming standard. So recognizing the critical calls, being able to have resources available for them. The difficult part is that many times those sources that are available outside of the departments are sources not familiar with public safety. So when that occurs, sometimes you're mesmerizing somebody else trying to help you because they're shocked by what you're telling them or dealing with. So I know we have our organization is NAMT's working on that, but the peer support is the important part, and that is also part of what keeps people and being able and showing that actively showing that you are concerned about their welfare. Where it becomes difficult is, for example, child cardiac arrest. So you pull an ambulance off and then you bring another crew that's one of our peer support people, but the calls don't stop. So, we're all overwhelmed with stuff, and, we have this responsibility. So, those programs are available, and I think most people do them, but it still is a very, I refer to us as the police officers of the medical field, because I don't even go out in the field much. And I was out a couple of weeks ago, got spit on 4 times. We had 2 medics, and we're in a very nice, affluent area. And I had a female medic that was punched in the ribs 5 times and grabbed around the neck. And her partner also was assaulted. Luckily, but this is happening. There's a change in, we've always had people like that, but there's a change in that, in the field, and whether it's fire, EMS, or police, where people are acting differently. So I'll get off my soapbox on that, but yes, there are programs we have to be attentive to keep and maintain employees, and but it's difficult to do.
We actually have a very active CISM peer support type team. One of our challenges is the amount of training that they have to go to, which is absolutely great. However, sending them to that training forces us to now have someone else backfill in their actual spot, creating other vacancies. If there was some type of grant or actual program to help us offset the actual cost of actually sending out personnel to these trainings, which are absolutely critical to the safety of all of us out here. That would probably help out some of the personnel issues that we're having with regards to maybe not necessarily having as active or as prolific a CISM PTS type program that we have out here. So any type of actual funding is always going to be welcome to help us all offset the cost of having these critical programs run either at the state level, county, city, in-house, whatever it may be.
I'll kind of echo those same sentiments. I know our organization has one of the most probably robust mental health programs probably in the state of Florida. We actually just got a grant for a peer support dog. So we take it very, very seriously. But to kind of echo Chief Edgar, the problem is we go out and we have a critical call. We send a rescue, an engine, however many people. We take everybody from that scene and we go do a debriefing. I have some areas that of the county where I've got a 15-minute response just on a good day. If everybody's where they're supposed to be, we've got 15 minutes to get there. Well, now I take them out after a critical call. Well, now what? I don't have any backfill. There's no depth. I can't even imagine how that's magnified in a more rural community.
Congress has the ability to make a very simple change to the Medicare Act, the Social Security Act, that will bring a lot of additional funding and availability to EMS, and that is to sponsor and pass payment for treatment in place, transport to alternate destinations, and statutorily require a change in how the Medicare rate is determined. Those three things, which honestly would be relatively easy from a legislative perspective in Congress, would fundamentally change how EMS is provided and how it's funded. Really an important issue in EMS is often thought of as an essential service, but as you heard others on the panel say, it's not funded as an essential service. So we can go to the next slide. We are that sweet spot in the middle. EMS has a role in healthcare, has a role in public safety, and a role in public health. When we respond to a car crash, we are serving in both a little bit of a public safety role, but certainly a healthcare role where we're providing medical care, whether that's a heart attack at home, but during the pandemic, and now as an extension of what many communities have now learned about EMS being a standing army of healthcare professionals that are trusted in local communities to deliver essential medical care. We're seeing that happen more and more. You heard Maria and others say that the patchwork of regulatory issues is a little bit difficult at times to navigate. You've got state regulation, you've got county rules, you've got municipal rules and regulations. So it's a patchwork of regulatory oversight. Then you've got the clinical oversight, which is medical directors. So navigating that sometimes can be a little bit different. So we often say that most innovation will occur at the local level. If you've got local leaders that are willing to try things differently. And again, you've heard about the different types of agencies that provide EMS. Volunteer is a big part of it. Where I am right now in Ohio, many of the services here are volunteer. Many of the country is covered by volunteers, and they're struggling just as much as the Philadelphia Fire Departments, just as much as any other EMS system. So it's the challenges that you're hearing about from the panelists, but also that you'll see here in just a minute on the presentation are irrespective of the type of service delivery model. They are all struggling. We can go to the next slide. So nationally, and we can just skip over this one, go to the next one. Thank you. So EMS systems are failing. You'll hear in a minute, 55 EMS systems have closed in the last 2 years. The primary reason for that, as you heard the panelists talk about, is a combination of the funding model and the workforce model. And we will tell you they are inextricably linked. You've got volunteer services that are having a hard time in today's culture getting volunteers. So they're trying to hire people to work in those systems. Well, there aren't a lot of people to hire, so they're stealing from Peter to pay Paul, and that creates just a vicious cycle of staffing challenges. You've got hospitals that are hiring EMTs and paramedics, as you heard Chief Edgar talk about. But the bottom line is that the expenses for the system have skyrocketed, and the reimbursement has not changed. We are still operating on a 1965 reimbursement model, which pays EMS for the transport, and most of our payers, Medicare and Medicaid, pay less than the cost of providing the service. The fact that we are only reimbursed if we transport someone to the hospital in today's healthcare world is heresy, because in the value-based model of healthcare today, where we're trying to improve clinical outcomes, improve the patient's experience of care, and improve the economics of healthcare, using the highest cost mode of transportation to take the patient to the highest cost location for care is not economically sustainable. And quite frankly, if you talk to most countries, they'll tell you that that's sort of very outdated and something that we shouldn't incentivize that type of non-value-based service delivery. Commercial insurers for a very long time have reimbursed at a higher rate than Medicare and Medicaid reimburse. The problem with that, with the changing healthcare insurance market, patients are becoming more and more responsible for paying for their own healthcare through high deductible plans and other plans that their employers may sponsor for them. When the insurance company doesn't reimburse the usual and customary reimbursement, that leads to the patient being responsible for more of that bill, whether it's EMS, whether it's the ER, whether it's the cath lab. We see that across the board. And that starts discussions about balanced billing and surprise payments. So that also is now challenging EMS economically. Next slide, please, Anna. Here's an example. So the Public Consulting Group does a lot of the cost reporting for the state ground emergency medical transport programs. Many states have programs where Medicaid will reimburse public EMS agencies for the underpayments that Medicaid makes throughout the course of the year. Part of the requirement for that is the agencies have to do cost reporting. We have to account for what it costs to put an ambulance in front of an address. And if you'll notice, in 2021, the Public Consulting Group gave us data on 385 agencies, and the average cost to put an ambulance in front of an address was $2,700 or $2,300. So if we use $2,500 as a standard across the country to put an ambulance in front of an address, the average Medicare reimbursement for that is about $400. The delta between $2,500 and $400 is the problem that we're having in this industry, in this profession, and we have had for a long time. Next slide, please. And again, here's the example. So in a location that we're working on in actually Maine, the average allowable Medicare fee for an emergency ambulance trip in Maine is $444. Of that, Medicare pays 80%. So the provider is getting a $358 reimbursement on a $2,500 cost. That is just crazy. And anyone will tell you that that is just, again, not sustainable. We can go to the next slide. We just want to give you these very specific examples about why this is a problem. Did we go back? I'm sorry, Hannah, we can go forward maybe 2 now. Oh, there we go. So we've been tracking, NEMT, American Ambulance Association, have been tracking news media reports over the last couple of years on EMS. And we've been able to track about 1,400 news stories. And we found that 57 of the news stories reported on a system that closed. And this is just one example from last week where another EMS agency had to close their doors in Minnesota because of the financial and the staffing crisis. And we can go to the next slide. So again, we're trying to give you that national perspective. NEMT did a national survey where we had over 500 respondents report on things like cost increases for personnel, cost increases for supplies, ambulances, medical equipment, you name it. And you'll note that there are 12, 14, in some cases, 20% increases in these costs, but the reimbursement for the services that we are providing has not changed dramatically. So this becomes a significant issue. And if you look at the lower left-hand side of this slide, the agencies that responded said these cost increases are going to continue. So the 9 to 19% cost increases, the vast majority of the respondents said, yeah, we know that these costs are going to keep going up. We have to fix the economic model for EMS. Next slide, please. So again, of that same survey, 370 or 34% of the news articles talked about funding crisis. And again, I just highlighted one in here for you from this month, where a county in Florida had to raise taxes to fund their local public county-based EMS agency. First time they've had to do that in 20 years. And if we had Medicare fix the reimbursement level, if we had things like payment for treatment in place, payment for transport to alternate destinations, that which brings more value to Medicare than us just schlepping people to the emergency department and spending their money, this would help a lot to balance some of those economic challenges that we're having in the profession. Next slide, please, Anna. So you've heard a lot about the workforce from the panelists. This again is a main driver in these systems failing, extended response times. You've heard everybody articulate the reasons why people are leaving the profession, why less people are willing to do it. This has been a crisis for probably a decade, if you were to ask some of the panelists, but it was exacerbated because of the pandemic and because of the national worker shortage in healthcare and a lot of other healthcare agencies looking to hire paramedics, looking to hire EMTs to work in those healthcare settings. Next slide, please, Hannah. And again, this is an example. So 59% of those national and local news stories talk about the staffing crisis. This is an example, again, from just a couple of months ago, where it's not just county-based services or volunteer services or rural services. City of Baltimore, their fire department runs the ambulance service, and they can't staff their ambulances. Chicago having the same issue. Again, it's irrespective of the type of service. This is just a national staffing crisis, which arguably is being driven a lot by the economic crisis. So we can go ahead once more, Hannah. This is not looking like it's going to change anytime soon because the number of people applying to come work for us in this profession, as you heard the panelists talk about, we were just in a discussion recently with some fire agencies on the West Coast, and they used to advertise for 1 or 2 positions and have hundreds of applicants. Now they're maybe getting tens of applicants. And in some cases, not even that. You're having agencies that are having to do $10,000 or higher sign-on bonuses, even at fire agencies. So the immediate and the short-term prognosis for this is it's not going to get any better unless there's really a wholesale change in how we fund and how we staff EMS agencies across the country. Next slide, Hannah. We've been testing new models. You heard Chief Edgar talk about the ET3 model, and others have talked about that. That is a much more high-value model for the patient, much more high-value model for the payer, and a very desirable model for EMS agencies who have long transport times, like in the rural areas, long at destination times where hospitals are keeping ambulances for 2-3 hours, sometimes longer, because they can't get the patient off of the ambulance stretcher into a hospital bed. The fact that we're not reimbursed for not bringing people to the hospital is just crazy. The fact that a telemedicine provider can get reimbursed for providing telemedicine to keep someone out of the hospital, but the EMS agency is not reimbursed for that, creates a situation where EMS is not willing to do telemedicine. Because if we do, we're shooting ourselves in the foot. So it doesn't make any sense. What we think is the premature termination of the ET3 model, and we just had a meeting with CMS about it yesterday, is really problematic and something that we're going to need to address in the very short term with hopefully some legislative relief that makes payment for non-transport or transport to an alternate destination the new economic model because it just works for everyone. You can advance the slide, Hannah. So again, economics, we've talked about it a lot. Here's just another example, USA Today, and we're in a rural community right now for the most part. It's really exacerbating itself in the rural areas, but ask anyone and they will tell you that, as we mentioned, Chicago, Philadelphia, Baltimore, LA, no matter where you go, staffing an ambulance in the community, and even in some cases, staffing first response medical units is becoming an increasing problem. One of the challenges that we had is that when Congress, during the beginning of the pandemic, provided a bunch of funding for healthcare to hire and build workforce development, none of that money was made available to EMS. So you had a situation where hospitals and other healthcare systems were provided federal assistance, federal funding to take our employees from us. And we didn't get any funding to try and be able to compete with now the new wages that were being offered through grants. We didn't have that opportunity. We need opportunities like that, like you heard some of the panelists talk about. Next slide, please. So the path forward is not looking good. We need additional training programs. I think Marie and others talked about this. We need to be reaching into the high schools. We need funding for workforce development. We need some congressional hearings on workforce development for EMS to find those other options that we can use to bring people into this profession. We need maybe Congress to support the development of a new emergency TV show. So as the chief talked about, people can now watch EMS in the way that they watch other types of professions and want to, like many of us did. I got into EMS because I watched Johnny and Roy on Emergency, and I thought that would be really cool, and I wanted to do that. And that they were great recruiters. So maybe we need to really talk about that, but really redesign the system, reimburse for the value that we bring, not the transport we provide, be able to provide a living wage for the providers of emergency medical services in the field, give them some stability, give them the peer support that they need to work through some of those mental challenges and those mental wellness challenges. If we don't do something now, the ambulance isn't going to come when you call. And we're seeing that now. Again, 57 systems have just stopped because they can't do it anymore. We got an email, any EMT got an email yesterday from a congressional representative from a rural northern state that said, so we just lost our ambulance service. What do we do now? And short of giving them a 4-page paragraph on the main issues, this is real. This is not something that we're predicting is going to happen. It is happening every day in this country, and we need Congress to help us fix this problem for the local communities.
Thank you for joining us for this discussion on the many challenges facing EMS. We hope that you found it useful. Also, a very special thanks to Congresswoman Dingell and Congressman Hudson for hosting this webinar, and I hope each of you have a great afternoon.